Hi, this is Dr. Hüseyin Avni Uludağ from Dünyagöz Hastanesi, Ankara. We are going to talk about strabismus today, or sequent. Strabismus is defined as ocular misalignment. A manifest misalignment is called tropia, and in contrast, hidden tendency for the eye to drift is termed phoria. Atropia causes diplopia if acquired after the age 7 to 9 years, whereas children under 6 to 7 years of age will cortically suppress vision from the deviating eye. And strabismus may be horizontal, vertical, or any combination of these. Strabismus broadly classified into committant and incommittant. Committant deviation is similar in all directions of gaze. Incommittant deviation varies in different directions of gaze. Etiology: idiopathic, related to refractive error, restrictive, example thyroid eye disease, paralytic, paralysis of extraocular muscles, and sixth nerve palsy, and sensory means decreased vision. Goals of the strabismus examination: to determine the presence of amblyopia, if any, establish a strabismus diagnosis, assess the binocular stages, fusion, suppression, and stereopsis, measure and characterize the ocular deviation, rule out underlying neurological cause. We begin the examination with history. Birth history is important, general health, developmental milestones, family history of strabismus, age of onset, and trauma and other symptoms. Headache, nausea, vomiting is important for neurological signs, and characteristics of strabismus: intermittent or constant, unilateral or alternating, and compensatory head posture and precipitory causes. We begin the examination with inspection. With inspection, we look at the eye alignment, fixation, head posture, visual acuity assessment for amblyopia, age-appropriate VA testing, and sensory testing for stereo acuity and fusion and stereopsis, suppression, ductions and versions for 9 positions of gaze, and oblique muscle dysfunction. Measure the ocular deviation, light reflex tests and cover tests. We measure the ocular deviation. Light reflex tests, Hirschberg and Krimsky. Cover tests are cover-uncover, alternate cover, and prism cover tests, and video scolopelagic refraction and fundus examination. In general, management involves correcting refractive errors based on scolopelagic refraction, treating any amblyopia, and orthoptic treatment and surgery in selected cases. Differential diagnosis for esotropia. Esotropia means an inward deviation of an eye, and these are infantile esotropia, accommodative esotropia, non-accommodative acquired esotropia, consecutive esotropia. There is history of previous surgery or exotropia. Cyclic esotropia is very rare. Concomitant ones: Duane syndrome type 1, sixth nerve palsy, Möbius syndrome, nystagmus blockage syndrome, and myasthenia gravis. Infantile esotropia begins from birth to 6 months of age. There is large angle constant esotropia, larger than 40 prism diopters, and spontaneous resolution is rare. Amblyopia is common, about 50%. There is associated motor phenomena after 2 years of age: inferior oblique overaction, dissociated vertical deviation, and latent nystagmus. And there's smooth pursuit asymmetry. It's tested with optokinetic drum, and this is deficient nasal to temporal pursuit, and this shows neonatal onset of strabismus. And the management of infantile esotropia: first, we need correction of amblyopia, and if deviation angle is large and larger than 40 prism diopters, and the angle stable or increasing, surgical correction is necessary. Surgery is usually recommended before 2 years of age in order to obtain peripheral fusion and some binocularity. Hypermetropia associated with increased accommodation to achieve a clear image, resulting in overconvergence and esotropia. We call this esotropia accommodative esotropia, and it's classified into fully accommodative and partially accommodative, with or without high accommodative convergence, accommodative ratio esotropia. Accommodative esotropia is acquired between 1 and 3 years of age, but may occur in infancy. The angle is variable, moderate to large angle esotropia, 20 to 50 prism diopters. The deviation is initially intermittent, then can progress to a constant esotropia associated with hypermetropia, usually +2 and +6 sphere. Family history is coming and may be precipitated by trauma or illness. Management goal for accommodative esotropia is to align the eyes as soon as possible in order to establish binocular fusion and prevent amblyopia. First, perform cyclopelagic refraction and prescribe full hyperopic correction. After spectacle wear, then evaluate for residual esotropia and fixation preference. If the glasses corrects the esotropia for both distance and near, that's fully accommodative esotropia, and single vision spectacles is enough. If the glasses corrects the esotropia for distance, but there's a residual esotropia for near, larger than 10 prism diopters, we call it accommodative esotropia with high accommodative convergence, accommodation ratio, and these patients needs bifocal glasses. And if residual esotropia is larger than 10 prism dioptry for both distance and near, that's partially accommodative esotropia and surgery necessary. Now we are going to talk about exotropia. Exotropia means the deviation of an eye outward, and in differentials we can see congenital exotropia, intermittent exotropia, consecutive exotropia, sensory exotropia, convergence insufficiency, and Duane syndrome type 2, third nerve palsy, and internuclear ophthalmoplegia. The most common form of exotropia is intermittent exotropia. Intermittent exotropia usually present after 1 year of age, and there is large exophoria that spontaneously becomes manifest. High-grade stereoacuity when the patient fuses 42nd of arc. When the patient tropic, there is suppression precipitated by bright light, illness, and fatigue. Intermittent exotropia can be classified into 3 types based on difference between near and distance deviation. Basic exotropia, distance and near deviations are similar within 10 prism diopters. And if XT is larger for distance than near deviation, we call it as divergence excess exotropia. And if the near deviation is larger, 10 prism diopters from the distance deviation, we call it convergence insufficiency type exotropia, intermittent exotropia. In the management of intermittent exotropia, we must correct any significant refractive error, treat any amblyopia that's present, and we can use fusional and convergence exercises based on prisms for conservative treatment, and we can, if the tropia phase increases, with diminished fusion control and poor fusion control on cover test, and the intermittent exotropia is manifested more than 50% of the waking hours, and exotropia is more than 15 prism diopters, and the angle increases. These are indications for surgery. In the general ophthalmology office, when we encounter a patient with strabismus, we need to decide if it's a neurologic or non-neurological causes. If it's neurological, the neuro-ophthalmology team will be called. But if it's non-neurological causes, then if the patient is child, then refer it to the pediatric ophthalmology and strabismus clinic. And if the patient is adult and strabismus is long-standing and stable, and the patient not keen on surgery, then discharge the patient. If the strabismus is sudden onset and deteriorating, and these patients, these adult patients, must be referred to strabismus clinic immediately, or if the strabismus long-standing and the patient keen on surgery, these patients must be referred for orthoptic examination.